I just wanted to thank you guys all for coming to this talk. And obviously, we know that IBD and mental health is a interesting topic and it's very important. And luckily, this discussion about IBD and mental health has become more commonplace for people with IBD. So I'm really happy. And Dr. Feldman actually has been on the forefront of making sure that when we treat IBD patients, that we're looking at all of those things, looking at the mental health and other aspects. So he is a board certified gastroenterologist with Cedars-Sinai Medical Group. He has specific clinical interest in IBD, which includes ulcerative colitis and Crohn's disease, with a focus on the psychosocial aspects of healing and disease. He obviously earned his degree. We went to Miami University and his medical degree from Indiana University. He's obviously done a lot of things. He also has his psychoanalytic, he has his psychoanalytic degree. And he is also getting an award on Monday, which he just told me, or he told me the other day, for the Master Clinician at Cedars-Sinai, which is a very prestigious award. So that's very exciting. And I also wanted to say that Dr. Feldman was really our champion to start our support groups when we started in person in 2017 at Cedars-Sinai. And he's been really a huge support to me and the whole program, but like a huge support, like a mentor to me with everything because we've definitely had some issues and things come up and I always call him and he, has helped me through a lot of things and also just to bounce things off us and make sure we're doing the best that we can do for all the patients. So thank you all for joining us and I'm going to hand it over to you, Dr. Feldman.
So my plan is to discuss this subject that is my primary interest, has been my primary interest for the past 50 years. And I want to talk about it in general and then leave plenty of time for questions that may arise. When it comes to questions, I wouldn't obviously want it to be the personal end of mental health issues, but discussing in broad terms is a better way to do it. So let me begin with a question. When we use the term mental health, what are we talking about? What is it that we are really referring to? What is mental health? And as I say that question to you, you're all thinking, what do we mean by mental health? So it's not a trick, but it's something that we can't talk about problems unless we know what normal is. And normal, to me, and everything I say here is, my opinion from my background and my perspective. It's our sense of well-being. When our sense of well-being allows us to think, to feel, and to act comfortably, that's usually what we mean by mental health. Now, the way I think about it is an airplane that's flying at 35,000 and just smooth as can be, but there's always a little bit of tumult. The mortgage is due. This didn't come through. Somebody screwed up my relationships. And so, but can we go back into balance? And when does a problem become a disorder? It becomes a disorder when it affects our ability to function, when we're not going to social events like we thought we would or could or should, when it's interfering with our ability to be in this constant state of what we would call homeostasis. Homeostasis means everything's even. And when the burdens get high, we have to adjust. So mental health is our sense of well-being. Well, another term that we use quite frequently, and as I ask fellows and residents in a teaching environment, quality of life. What do we mean by quality of life? Everybody uses the term. How's your quality of life? Or what do you feel about your quality? Well, again, what are we talking about here? What do we mean? So I want to propose the following definitions, which I think is very understandable. Uh, I break the life into three domains: work, play, love. Okay, work, play, love. Work, what we do. We teach, we talk, we are accountants, we're students, we're retired, but we garden, we do this. Whatever we do that would be in the world of occupation work, that's work. Play is reading the novel, watching the television, enjoying company, cooking if that's a pleasure to us. Whatever we do that we would fall into the play or recreation area. So we have work, play, and then love. Love meaning relationships, being able to have thoughtful, feeling relationships with others. And it always varies, but work, play, love, those are the three domains. And now the quality of life is, what is our sense of satisfaction with those three domains? So when we look at our work, our play, our love, what is our sense of satisfaction? And you can't give it a numerical, but you can give it like coffee from a coffee shop, small, medium, large. I mean, we can give a sense of where we're at, and we as individuals can usually pick out where we're deficient in the work, play, love. And so I think that those are important concepts. What is mental health? What is quality of life? So I guess the next question would be, what or how do mental health issues affect patients with IBD? Are they prominent in IBD? I guess that's the real question we're asking. And the answer is, well, we have to first look at baseline. Baseline control populations, anxiety, and we'll just use these two categories for simplicity. And I know it doesn't cover everything, but we'll talk about anxiety and depression because they're the two major players. Minor players, they're not minor, but they fall under sleep ability, coping ability, issues like that. But let's talk about anxiety and depression. In the normal population, clinically relevant, I mean, let me step back. There is nobody who doesn't experience anxiety. I mean, that would be right upable. Everybody experiences the blues, but it's not a depression that necessarily keeps us from functioning. So I just want to put that into perspective. The anxiety in the general population, which is pretty standard, is about 15% of the population. And about 8 to 10%, let's say just say 10% for discussion purposes of the population, have clinically relevant depression. So that's where we stand in the normal population, about 15% anxiety, about 10% depression. When we look at the inflammatory bowel disease patient population, the anxiety goes up to 30% for clinically relevant anxiety, and depression rises to 25%. So basically, we double it in the inflammatory bowel disease population. And I'll come back to which is the tail and which is the head here, because that can become tricky too. Now, what happens when patients flare or have an exacerbation or get really sick, whatever we want to call it? The anxiety can double to 50% and or anywhere above 30%, and depression can go up to 25%. So what's interesting about that is that if when the patient improves and gets better, goes back to the baseline, which is still double and still needs to be addressed. Well, that's a good question. Why do we need to address it? Well, we know that patients with anxiety and depression tend to be, not, this is not precise, but tend to be less compliant. Less compliant means they may not take their medications, they may not show up for infusions. They tend to use the emergency room considerably more, statistically more. They tend to have more CAT scans and other imaging studies more. They tend to have more hospitalizations and even more surgery. So it does affect the management of patients with inflammatory bowel disease. Well, why would patients be more anxious or more depressed? Well, there's a lot of stressors that go along with having inflammatory bowel disease, and I want to talk about them in a moment. But I want to just refer to another study, two studies actually, that are impressive and probably should be included in this discussion. And that is, when we look at the population in Manitoba, Canada, that province has a very, very tight medical history kind of system. So they can pull the patients with depression or anxiety and or medications for anxiety or medications for depression. And when they look at their population and inflammatory bowel disease, what they learned was that they could see the depression in particular presenting up to 5 years before any symptoms and any suggestion of inflammatory bowel disease. So initially, one would say, aha, isn't that interesting? Does depression cause inflammatory bowel disease? And the answer is absolutely not, nor anxiety. But I propose to you that the two might run on the same DNA pathways, so that if you have a propensity for one, you might have a propensity for others. The genetics get very complicated, but we're going to learn more as time goes by and be able to sort that out. But in the meantime, let's just take a peek at what patients with inflammatory bowel disease face or are confronted with. And this list is by no means exhaustive, by no means. The first, and to me, the most prominent, is uncertainty, because uncertainty equals anxiety. And you can put that in any context. The most simple one that I think of is if you've ever walked into a cafeteria that you've never been to before. Where do I pick up the silverware and the napkins? And oi, the peas are over there. No, did I miss the salad over here? Anything that's new, anything that's different brings uncertainty. Now you bring a disease, a medical disease, to often very young people, though we certainly see the onset in the 60s, 70s, and even 80s, but to primarily the audience of IBD patients is between, the majority started or between 10 and 30. The bottom line is that uncertainty is remarkably apparent and heightened by knowing that there's going to be a lifetime of challenges. So the uncertainty isn't just at this moment, but it's going to continue on. There's clearly a threat to function. Will I be okay? Will I be able to tolerate symptoms, medication, surgery? I don't know what tomorrow is going to bring, but I know that it might be difficult. So we have this constant threat. We have pain. Not everybody, but many patients suffer pain, and they suffer a lot of pain. That's a huge stressor. Diarrhea is one thing. Diarrhea with urgency, very common in inflammatory bowel disease, is a game changer for people. Urgency is one of the most difficult issues that one can imagine having. not just the practical aspect, but the psychological aspect of can I get through the grocery store and get home? Do they have a commode? Will I make it? And often patients don't. And then that just triggers a whole lot of psychological issues of shame, of guilt, of feeling, that this is not acceptable. Bleeding, bleeding. That's not normal. I mean, blood's supposed to stay in the circulatory system, not be coming out of our rectum, and it's very disconcerting and very stressful. Will Will I be able to tolerate the medications? I hear they're very powerful, and I hear that they affect the immune system. That sounds a bit scary to me. How will I be able to cope with these medications? How will they affect me? Will they alter my life? Will they alter the way I feel? Oh, I've read that there's a increased risk of cancer in patients with inflammatory bowel disease. That's pretty scary, and that's a big stressor. Just a moment on that. The reality of that is it isn't very common, but it does occur. And because it does occur more than the typical rate for the normal population, we not only have to pay attention to it and concern ourselves with it, but we have to monitor. So these are additional issues. The need for will I need surgery? Will I have disfiguring surgery? Will I have to have an ostomy? Will I still be lovable? Big time stressors, big time stressors. And then I put in concern for others. Lots of patients worry about their parents because they see their parents worrying about them, or vice versa, whatever the relationships might be. It's a stress on the family. So it's not just the patient, but it's the patient within the family organization. And well, what about future generations? Will I pass this on? Well, we know it's genetic. We know that the odds of passing it on are not all that much, but they're not nil. Generally, we throw out figures about 5 to 7% if just one parent has inflammatory bowel disease. But it's still a concern. So what I'm getting at is that there's all kinds of reasons to be anxious and depressed, and they trigger what we already have stated as our baseline problems. Well, how might the mind affect the body in the setting of inflammatory bowel disease? Mind, body. All right, we have to keep that one going because there is no mind and a body. It's a body-mind. It's all the same. Hardly any of you would separate your kidneys from your liver, Well, the mind is an organ. It's a distinctly unusual organ, but so are all organs that do things when we think about it. So we have to begin to think about this concept of duality, which took over in the Western world in the 1500s, and still to this day, there is I would think the majority of the population sort of thinks about their mind as sitting up somewhere above their neck, where the body has its own functions. It's not the way it works, and now we know it. Sigmund Freud used to say, I know it's close. I know that there's a relationship, but couldn't put its finger. Now we can. Now we know a lot more because we understand a bit more about how neurons in the brain talk to each other and connect. We know that that must happen because we have thoughts. Where do the thoughts come from? From neurons that are connecting. Well, thoughts are where it begins. Thoughts lead to feelings. Now, feelings are very interesting. They're the most interesting to me because feelings are very private. I can never know what you feel unless you share it with me. Feelings are totally private. You never know what somebody's feeling. If the feelings then lead to physiological changes, which we then call emotions, I could tell you're angry. I could tell you're sad. I could tell you're happy. We can read emotions in each other, which may represent the feelings, but not necessarily. And so it gets very, very complicated. There is a phenomenon that I have seen, both having known the literature, but more have actually seen it occur, that has nothing to do with the gastrointestinal tract. But oh my, does it make clear the mind-body relationship. And I use the word mind-body for purposes of discussion now that you're hopefully convinced that I believe that it's all one. Takotsubo syndrome. Takotsubo syndrome. Not many people know about it, but it is becoming more and more apparent. The patient would present with chest pain and all the appearances of a heart attack. Absolutely classical heart attack. The ventricle, part of the pump of the heart, the left ventricle balloons out. It balloons out so that it takes on the shape of a Japanese octopus catcher. It's called a takosobu. Is a piece of pottery with a branch out, which represents the left ventricle, and then it comes in, and that's how they catch octopus. But so that's shaped like that. That's the only reason it's there. What happens is that typically in about 5 or 6 days, it goes back. Oh, these people they've been angiogrammed, they've gone through all the testing. There's nothing but this failure of the heart, which then typically in about a week, although there are more recent reports of several weeks, but in a relatively short period of time, goes back to being absolutely normal. Why do I bring it up? Because it's stress related. It can be physical stress from overexertion. It can be emotional stress from pressures. It's a phenomenon of which there are many such types of relationships, but this one is so striking that you can't ignore the relationship of what the mind experiences and what the body then pays for. And we know it goes the other way too. The body influences the mind. Nobody has been constipated. Nobody's had a distended belly. Nobody's been vomiting or nauseated. Nobody's had impending diarrhea without feeling awful in many ways, in different ways. So what I'm trying to set up for you is mind-body goes back and forth. And how does it do it? Well, it does it hormonally. The pituitary, which is in our brain, releases hormones that affect the adrenal gland. The adrenal gland releases hormones which affect the mind, the body. The nervous system, the vagus nerve, big nerve, comes out of the brain, goes down throughout the gut. It sends messages down from mind to body, and we know that body to mind goes right back up again. And now we're learning about the microbiome, the 300 to 500 trillion with a T bacteria that live within you. Every one of us has about 4 pounds of bacteria, and yet you can't see one of them, let alone 1,000 of them. Trillions exist, and that relationship changes. Can change with disease, it can change with stress, it can change with diet. It's very influential and may have more influence on our gut for sure, and maybe our entire body. This is an exciting area. We've known that there has been a microbiome. We've had it implied for several decades, but only after President Obama came into office and he pushed through the National Institute of Health Microbiome Genome Project, we now don't have to grow the bugs. We have these the capacity to detect them with tools that make it so much faster, so much easier. Not easy, but much faster and easier. So that's why we now know a bit more. And we know that the microbiome diversity, this is, we can put it in a population way if we're so inclined, and then say diversity is good. Well, normal people have a much more diverse microbiome than patients with inflammatory bowel disease. And a lot of this is genetic. So these are pieces of a puzzle: hormonal, nerve, microbiome, that respond to various inputs and influence our gut and influence the way we think. Well, how does this affect management of care? I think the first and most relevant is we want to become better at identifying these patients who have the disorder, not just anxiety. I have anxiety. Almost everybody has anxiety, but is it a disorder? Does it keep you from functioning? Identifying those patients with impressive anxiety, identifying the patients with clinically relevant depression is very important. And so we in the field of inflammatory bowel disease are now looking faster, sooner, harder to figure out and find these individuals so that we can help them, because they're not going to necessarily walk in and say, oh, and besides the fact that I have Crohn's or ulcerative colitis, I also have anxiety. People usually don't discuss that, but because it's so influential in the management, we want to identify them. And then we want to encourage everybody, but particularly these patients, with the obvious measures of well-being. It's pretty pop now, and I'm glad that it is, but everybody benefits, and we as physicians and those of us in the healing arts, reassurance and having a supportive relationship is really, really important, so that patients can learn to trust us and trust us with their feelings, if not just their emotions. Diet is important. What we've learned from my experience, at least with support groups over the decades, has been that everybody's interested in diet, because gut, diet, they seem to be associated, but they are associated. And there is no one diet that is right, but we should all think in terms, especially those of us who do not have inflammatory bowel disease but just want to lead healthy lives, that in general, unless we have a specific problem, we want a Mediterranean diet. Mediterranean diet is the bottom line, good health way to go. Sleep is very important. The data is in. Less than 7 hours, people do not function as well as they do when they get 7 hours or more. I spent decades wishing I could get 7 hours, and it's kind of interesting that we all go through these phases of, is sleep a waste of time? Not a waste of time. It's really crucial to good health. More than 9 hours is probably overdoing it, not in our best interest for possibly mechanical reasons of our body and in motion. So it's very important. We kind of aim for 7 to 9 hours. Being active is really important. Sedentary is to be avoided. unless you're nurturing yourself because of a recent illness when you have to do it. You just have to take care of yourself. But being active and being as active as you can comfortably be, depending on one's schedule, very, very important, very crucial. And perhaps the least recognized, but the most important part of well-being is connection to others. And sometimes that's very obvious and very easy because you're in a tight family group, it's supportive, you might be in school, lots of friends, or you might lead a relatively isolated life. And when that happens, it's really important to do what you can, whether that's getting a dog and walking around and meeting everybody else with dogs, or taking, counting steps per day, or choosing to park at the far end of the parking lot so that you have to walk further to get to your car when you're in a big parking lot. Whatever it might be, activity and connection to others is absolutely critical for well-being. So we always start with those issues. Well, how do we approach these patients with anxiety and depression? Because we have established that we have a belief that it's important. Well, first and foremost is the obvious. Caring. We have to care. I'm always quoting Francis Peabody, who was the medical director of the Harvard Medical Unit in 1927 when he wrote this article. And the day he submitted the article, he apparently went home and told his wife, of all the scientific articles I've written, I think this one is going to be more important. And lo and behold, here I am 100 years later quoting it. The secret to the care of the patient is to care for the patient. Hard to teach. I'm not sure that it is teachable. That's been my frustration being in the teaching environment for the last half century. It's in the DNA, I think, to a certain degree. You can emphasize it, but if you're not a caring person, you're not a caring person. And caring is very, very important from our point of view as health providers. Social workers have a great deal to offer patients because so often it's insurance issues, and God knows we're going to be back in that mess again with people who may be uninsured and how we manage their inflammatory bowel disease, or try to under the circumstances. But there's lots of little things that social workers do in our environment, from jury duty notes for somebody who's having 15, 20 bowel movements a day. They're not good candidates for sitting in a jury area. There's a gazillion things that they can do in addition to being supportive, caring therapists. We use medications. There is a lot of advantage to medications in both anxiety and depression, and those of us in the field should have a comfortable feeling for basic use of these medications, simple what we call SSRIs, or the anti-anxiety, anti-depression medications, which may be necessary. I wouldn't throw them around. I don't use them like a salt shaker, but sometimes they're absolutely necessary, and we should do it. And then, of course, we always want to arrange appropriate counseling referrals, whether that's to a psychologist or a psychiatrist. We have to have that avenue, and so I think that in the system we have to continually focus and embed those referrals into our system, which we have now. Family members are affected all the time. Ask a typical family member, of which I suspect many of you are those family members. It's almost a constant sense of feeling helpless. unable to control certain issues that we wish we could control, whether it be our spouses, whether it be our parents, whether it be our children. And it becomes stress in its own way. It's bidirectional. The patient can upset the family can upset the patient. Over monitoring, over controlling, over watching can be disturbing. On the other hand, we don't want to be uncaring and dismissing. And I haven't met a 13-year-old that you can say, "Well, go take care of yourself in life." You know, it's they need support. Do I, as the patient, do I, as the caretaker or family member, do we have the right doctor? What makes the right doctor? Availability? Cost? White coat? Title? For different people, it's different things. But it's always a question. Do I have the right doctor? Do I have the right medication? Am I on now, up until 1998, our hands were rather tied. Let me go back even further. In the 1940s and 50s, when these diseases were just becoming prominent and studied, remembering Crohn's was not even noted until 1932. That's not very long ago. The treatment was rather easy. Take a patient with bad diarrhea and put them in bed. Bed rest actually is pretty good for diarrhea. It works. We didn't have anything else. They used to, because there was at that time a thought, well, this must be a psychosomatic illness. What else could explain it? Which is completely incorrect. But it was a big movement in the 50s, and putting patients in the hospital and just isolating them from a family was what was done. And then came medications, first sulfasalazine, which was very effective, prednisone, or corticosteroids, and antibiotics came in and they became more prominent. In 1978, we had our first thiopurine, a drug called 6-mercaptopurine, and then a sister agent, methotrexate. And that's about all we had till 1998, when infliximab, known commercially as Remicade, was released. And now, I've lost count, but there are a minimum of 15 different agents that are readily available if the insurance companies will allow to cover it, and many more in the pipeline because of the development of antibodies that we call them monoclonal antibodies, that brought in the age of what we have referred to as biologicals. Now we have a couple of non-biological agents, so we're changing the name to advanced therapies. Advanced therapies include the biologicals and include what we call these small molecules. Small molecules are upadacitinib, which is known on TV as Rinvoq, estrasimod, which is known as Velsipity. These agents are pills. Who would have ever dreamt that they can get the effect that they have by an oral medication that's then absorbed? I still remain totally fascinated by absorption. I mean, you have an egg salad sandwich for lunch with some bread and potato chips, and somehow that's broken down to simple sugars and simple proteins, simple amino acids, and simple fatty acids, and incorporated into our body and made into us. That's beyond language from my point of view. And then you take a pill, and how does that do it? Well, science, research, all the things that are presently being threatened at the moment. So my point being that members of the family need attention, and that's where we come to support groups, and not everybody's for support groups. But I've been in and out of support groups for several decades, and I think that in general, they're wonderful for people who want to participate. and want to either provide the support or get the support, it's really, really useful. And it may be one of the good things that's come out of the pandemic is the fact that support groups can be online and be pretty darn effective and certainly save, in our case, a lot of driving and traffic and all that. But the idea of being able to be at home or in your office and connect to a support group can be very, very effective and very, very useful. So my hat has been off, and that's why I was eager when Stacy invited me to meet and to discuss the idea of having support groups within Connecting to Cure. I think it's a fabulous idea and one that should be maintained. Again, I often ask, why isn't everybody part of a support group? A lot of people don't want to do it. A lot of people just want to be by themselves and take care of themselves and don't feel that it's useful. That's why we have horse races. Everybody has the same data and we all think different things. So that's the way it is. What's the future of mental health in IBD? Identification and recognition of those who are in need. Get it done sooner. Resilience is a remarkable phenomenon, skill to have. We need to better understand resilience, and we have to learn how to train or teach resilience. Some people have it naturally, but most of us don't. And it's an area that I think we need to pursue aggressively. Medication trials for anxiety and depression within the field of inflammatory bowel disease, and I would love to see head-to-head control trials. These are very difficult, very expensive, and it's probably the only way we can do it is to do multi-center cooperative studies, but I think it should be done. And we also need to explore non-medication approaches. Lots of us recognize that Western medicine is a slice of the pie or the pizza, but it isn't the only slice. There's other slices that are out there. They don't have as much science behind them, so they don't have evidence. They have anecdotal evidence only, but yoga, exercise, even hypnosis, we could go on. They're all worth investigating and looking to see what would work best for the patient population and the family patient population. So I think my bottom line is the traditional application of medications and the correct use of surgical intervention, we're getting better and better and better and better. Better medications, better surgery, better decision making, but we still have a long way to go. And attending to the psychological aspects may well improve outcomes and improve the patients and the family members to have a better, to have an improved quality of life, which is the ultimate goal. I'm going to stop now and encourage. I saw a chat flashing, but I can't read them as fast as they were there. But if Stacy, you would help me, if there are questions, I'd be glad to make an effort to answer them.
So I just put it in the chat that people can ask questions, but I have a question. I mean, there's a lot of interesting things you said. So how do you, I know that like when patients, there are certain screening tools for mental health when you come in, but how do you assess patients?
I do it pretty much in a clinical way because I have the opportunity, a blessing that I can take the time because they allow me to do that. And so I don't have to rush. I was an Army doc for 2 years being drafted at the end of the Vietnam period. I was assigned 10 patients per hour, 6 minutes per patient. Not my kind of medicine. It just can't be done. So I here in my office do not use the tools, but when I work with the clinic, we do use the tools. Everybody gets screened when they come in, and we're planning on improving that so that it's easier, and then it becomes part of the medical record, not in what the issues are, but to pay attention to this issue so that we can address them. And if you come out on the surveys that we do with a high anxiety or high depression, it goes bing, and we will pay attention to that patient and seek them out and see what we can do.
Does anybody else have a question? I had another question, which was about like mental health and disease outcomes. Is there any studies on that, like about improving mental health and then your disease getting better?
Yes, they're they're not great studies, but staying with the concept uh, of if you improve these areas, do patients do better? Their outcomes are better. We're pretty sure that that applies in inflammatory bowel disease, and I don't think I have any personal doubt about it at all because I've watched it happen. But that would be anecdotal. We want the evidence, and so it should be pursued.
Yeah. Okay, there's a question. Do you think the decrease in stigma associated with IBD over time has had a noteworthy impact on patient anxiety, depression?
It's an interesting question because there are really two there things implied. The stigma of IBD has got to be overcome by doing, for example, what this organization does, and it's when you have a sore thumb, people say, "Oh, so sad, too bad." But when you have gut issues, people don't like to talk about it, and they don't want to understand it, and that will only be corrected with exposure and time and the ability for people to grow up and understand that bodily functions do not always work well. And somehow, if you have a breathing problem, that's more acceptable than you have a diarrhea or a bleeding problem. But then we reach the stigma of mental health issues, and you know, people, patients are not really fond of saying, "And I have this issue." Would I like to reduce the stigma? Absolutely, absolutely. And I think that that comes from people talking about it and having it on the list of, we don't have any hesitation to talk about medications or surgery. Why should we not be talking about mental health? So it's a matter of time. And I've been at this since I started in the national when I was a fellow in 1976. So I'm talking, well, we're talking 50 years. The bottom line is that I think that there is a lot less stigma, and I think that what you implied in the beginning is I've seen it go from, "Hey, am I the only guy who's thinking about this?" to it's there were two journals last month that on the cover had IBD and depression, or depression and IBD, as the cover stories. So it is in the public view, and we know from other institutions that do what we do on the East Coast and Midwest that we're all chasing the same thing: is to figure out how to do it better,
Yeah.
how to improve it. But it's now part of the zeitgeist of inflammatory bowel disease, which I'm very pleased about.
Yeah, I was gonna say, I was wondering about how you've seen the changes over the years, but you addressed that. There's another question. Do you have behavioral health professionals embedded in your clinic? I think this also reduces stigma when they are side by side with medical professionals.
Well, not enough. We have one in our clinic now, but I want four. It costs a lot of money, and these are the issues that we're facing. So that if you need another surgeon, somehow you get it because they're so remunerative that it's easy for an institution to say, "Oh, you need another surgeon of this sort." When it comes to mental health, there is a great need for increased philanthropy and increased institutional contributions, because I think that the more we have, the more patients will say, "Oh, this is part of my treatment. This is what I do."
Yeah, I think that's what she was saying, because it's seen as more credible if it's just, you see the doctor and then you see the mental health person.
We like this idea of having an IBD home where we can do it all, and where you can get dietary information, nutritional information, where you can get your medical information, your surgical opinions, and your mental health issues. They should all be part of an IBD home, which is what we're going for.
Yeah, I agree. Betty, do you have a question?
Yeah, I have a question about like PTSD, just how it resurfaces. Like you can be going along just fine for many years, and then a situation comes up and you have that again. And is it just something that you go through as a patient, and then you add all these, you do your activity, you have your connections, you do your work, etc., and then it just goes back to the homeostasis?
Well, that's the idea, but I'm going to tell you that the acute management of PTSD is above my pay grade. It's not that I don't want to, but it's really very, very difficult. And uh, I see it all the time, particularly with adult patients who had their onset in childhood. I've gone so far as one patient I had to take from my office down the elevator, across the bridge, walk in to the hospital, and turn around, walk back out again, just to desensitize. That's how frightened she was, how horrible, not horribly, intensely PTSD she was about being a patient when she was a kid. And that's an extraordinary example, but in little parts, we all have it and we all see it. And anybody who has been in a hospital, they're not good places. And we're a pretty good hospital, but there's no place like home. No place.
Yeah. Um, Thank you. Any other questions?
Yeah, hi, Dr.
Hi,
Feldman.
Dan.
That was great. Really great. As far as PTSD as a follow-up, are there studies being done around that? IBD and PTSD or
No,
probably more.
not that I'm aware of. Not that I'm aware of. And I follow that literature pretty close, obviously. And, no, not yet.
Yeah,
Okay.
I mean, I wonder if there's other studies just on other medical
Yeah.
and and just in general, medical trauma and health. But yeah, definitely have a long way to go. Need more of that.
Yeah.
Anybody else?
Can I ask another question?
Yes.
Um, you've mentioned that they're working with virtual reality in the clinic, I think.
I
What
didn't
have you
mention that
seen?
tonight, but that's uh, we have a virtual reality treatment program that my colleague Brennan Spiegel has been pursuing very successfully, and I think that there is a great future to that technique from a calming point of view. It's easy for me to say, "Oh, why doesn't everybody meditate every day?" What are we talking about? What do you mean meditating? Well, everybody's got their own perspective on what that means, whether you sit, whether you walk, how you do it, how you breathe, etc. But some people just cannot calm themselves, and the virtual reality is a tool that appears to be very, very effective. So the science of it is just getting into it.
Yeah.
We'll know more in 5 years.
Yeah. All right, well, if no one else has questions, thank you so much for taking time out of your busy schedule, Dr. Feldman, in your evening to have this incredible talk for us. There is one more question, actually. Do you foresee a time in the near future where a permanent ostomy bag can be reversed using 3D printed technology?
Uh,
Different subject, but I'm
yeah, no, 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 but I understand it. And of course, as reading it as you were reading it, permanent means permanent. And the answer is I don't know. I don't know.
yeah. Um, Thank you. Thanks everybody for joining us. We're going to send a survey and we also can send the recording after. And, make sure you stay tuned to our other speaker series that we have coming up. I don't think we're having any more this year, Betty, right?
No, next one's
Next
January
January.
20th.
Yeah. And then but we do have our Rock the Night event on November 15th, if, here in LA, if anyone wants to join, and then we can help fund Dr. Feldman's psychosocial program and IBD home. So that's part of what we're hopefully working on. So, and if anyone wants to reach out, don't forget about our support groups and, just reach out to us if you need anything. So
Thank you for inviting me, Stacy.
thank you. Thanks, everybody. Good night.